stress disorder symptoms. They further recommend that when PTSD symptoms are present, that they want clinicians to be evaluating the severity of those symptoms and the degree of impairment. Because if you've got one level of impairment, your treatment options might be a bit different than if you had a very high severity of impairment. And to also be looking for differential or comorbid diagnoses. So the treatment options are going to be a little bit different if there's multiple mental health issues going on, or like a substance use issue. They also recommend that when it's possible, because it's not always, to involve parents and caregivers in the entire process. So the evaluation pieces and the treatment pieces. And sometimes that evaluation might actually, you might even want to pull in people from the school systems, because teachers and counselors in the schools can see things and behaviors and symptoms that we might not catch in other settings. So they definitely recommend that once you do have a child or adolescent with post-traumatic stress disorder or some level of acute stress disorder, that the treatment planning needs to be very comprehensive, and it should include the school personnel, being able to get them involved in either managing some of the symptoms and behaviors that might occur during the school day, or figuring out what types of other interventions the school can help with. Some of the treatment planning needs to also involve education for the parents and the kids about what PTSD is, so that they can be empowered and understand more about what's going on. And they highly recommend collaboration between primary care and mental health clinicians. So if it's a pediatrician providing any of the medication types of things, then that's awesome. And if it happens to need a psychiatric nurse practitioner or psychiatrist, then using that level too, but everybody really being closely coordinated and continually working together. The treatment recommendations, so there was really two arms of it when I was working with youth with PTSD, and that's the frontline treatment really is trauma-focused psychotherapy. That's considered the best first approach, and there's a variety of types of trauma-focused psychotherapy, but they absolutely recommend starting with that, and then adding on adjunct medications if the symptoms aren't fully working, aren't fully persist, or if they're persisting past psychotherapy being used. The one that has the most research to it is trauma-focused cognitive behavioral therapy. And even within the article that I read and some other pieces that I've looked at, trauma-focused CBT it's almost kind of the underpinnings to most of the other types of therapies that are out there. So there's a CBT component to almost any of the trauma-focused therapies. Traditional trauma-focused CBT would look at psychoeducation for the kids and the parents, sometimes enhanced parenting skills, depending on where the parents' capabilities are. We're looking at coping strategies, relaxation skills, and affect modulation strategies, so even sometimes including things that you might find in more of a DBT framework, so teaching kids how to identify and regulate their emotions a bit better. There's a cognitive processing component of this, and where I have seen this used specifically is in trauma-focused narrative therapy. So helping kids to actually create the story of what happened with their trauma as a way of actually working through those cognitive skills. And sometimes that's more or less helpful depending on the kid. Enhancing safety and future development types of things. So getting the kid to feel safe and be future focused. A huge piece, and it can be a huge piece of the narrative therapy as well, in trying to give a story to what had happened, but also start to create some of the ideas on the story that we would like to see happen as the future moves forward. Parts of that can be, if the kid is open to it, a gradual exposure to some of the reminders and eventual mastery of those reminders, so that they can feel confident in their ability to be exposed to possible triggers or things or places that might remind them of their trauma without having to be debilitated by it. They also recommend participation of the caregivers in this entire process only if the caregivers are safe. So I think a big piece of the focus here was knowing that kids with PTSD in many situations have been the victims of abuse or neglect by their parents. So you don't want to involve an offending parent in this type of therapy, even siblings. So making sure that only the people who are safe people are invited to participate in this. So some additional evidence-based CBT types of modalities that they had outlined in this article that I thought were pretty good is a cognitive behavioral intervention for trauma in schools. So this is kind of cool because it's a group CBT protocol. So if you've got multiple kids in a school who all have PTSD issues, this is something that could be implemented there. It includes education for the teacher about the impact of trauma on behavior and learning. So the teacher is better able to not make things worse and to be better able to interpret what's going on with the kiddos in class. And it does include one-on-one sessions with the group therapist for the kids to work through any of the trauma narrative pieces. So it's a pretty well-rounded treatment modality that is able to get to a lot of this, but also create some peer support and just better social interaction amongst the kids. Another one was Seeking Safety, which was a manualized CBT-ish protocol, but it was specifically developed for interventions that looked at PTSD and comorbid substance use disorders. So it focused a lot on assuring safety in the present moment, and it was a manualized program that you could implement on an individual level or in groups. So there is pretty good evidence that when you can involve the parents or caregivers in the treatment, that's actually really helpful in the child's resolution of PTSD symptoms. So one of the authors here, they had looked at trauma-focused CBT if it was provided to the parents alone, the children alone, or the parents and children, compared to treatment as usual. And parental inclusion in the treatment was, you definitely saw a much better improvement in the child's depression, and the parents reported behavior problems that they witnessed with the kid. There's also other studies that have looked at involving parents in the child's treatment, and there's a lower level of parental distress and a stronger parental support that you see by involving parents in the trauma-focused CBT. So this one, they didn't talk about too much, but I actually have a fair bit of experience. I've gone through the level 1 training for EMDR. So eye movement desensitization reprocessing. It's a treatment method that uses CBT types of techniques combined with bilateral stimulation of some sort. So they mention eye movement, but it's not always eye movements. It can be eye movements. It can be alternating sounds, so snapping your fingers on one side, one ear, and then the other, or it can be bilateral stimulation of even tapping on knees, or having kids, if you cross your arms in front of you, tapping alternately on your shoulders. So there's a lot of ways to do it, but it's a very interesting treatment method, and it has a lot of literature in adults, particularly with veterans. There's not a ton of literature on kids, but I think with teens in particular, on that older developmental spectrum, I think that this could be potentially very useful. The thing to be very mindful of with EMDR, though, is that while it is a very effective treatment method, there is a fairly intense protocol for training. So you don't want to send somebody to somebody who's not had a good amount of training and ongoing supervision. Like, I've been trained, but I haven't practiced or been supervised in EMDR in a number of years, so I wouldn't try to take a stab at that at this point in my career. They also talked about psychodynamic-based trauma-focused psychotherapies, and this is definitely an area that I have less experience in, but the idea is to promote personality coherence, development, and achieve resolution of traumatic symptoms. It's thought that the unstructured nature of the sessions can be helpful in helping adolescents regain more of an internal locus of control that might have been lost. And it has been shown to be superior to group psychoeducation when you compare individual psychoanalytic psychotherapy to group psychoeducation in decreasing PTSD. sometimes I can't see the top of that. So pharmacotherapy, what I was able to get from Andrea, and once we kind of spin through these, or at any point, Andrea, feel free to jump in, but there's been no real large randomized clinical trials available to guide choices for the treatment of PTSD in kids. I mean, we have large randomized studies for adults, but that doesn't exactly exist in the pediatric population. There are 2 SSRIs that have been approved by the FDA, sertraline and paroxetine, and there are currently no SSRIs that are FDA approved for the treatment of PTSD in a pediatric population. However, if one does choose to use the off-label use of SSRIs to treat this, it is thought to improve social and occupational functioning and to decrease core PTSD symptoms, so decreasing the avoidance, numbing, dissociation, with the potential added benefit of treating any kind of comorbid anxiety or depression. Andrea had told me that they would recommend starting at a low dose with gradual escalation and continual consultation with the child psychiatrist and close monitoring for any of the suicide ideation. And with note to be very mindful in working with the parents to obtain appropriate informed consent so that they are aware of the FDA's black box warning regarding suicide. Additional options could be beta blockers or alpha adrenergic agonists.
Good job.
This is why I did not go into anything like that. Examples would be guanfacine and clonidine. If used right after the onset of symptoms, can be shown to reduce arousal, decrease the forced re-experiencing of the trauma, and avoids neuropsychologic kindling that can contribute to chronic illness. Again, I feel like this is tongue twister today. Mood stabilizers can also be effective for the same things once the illness has become more chronic. And atypical antipsychotics, while they have been used, should be considered only when the patient is unresponsive to other medications, or if there's psychosis or some type of marked agitation. And I know a lot of other treatment methods and options, and for the sake of time, since we need to keep these didactic portions short, I didn't want to go into the exhaustive list, but anything that any of you would recommend or treatment options that you've seen in place. I know that at Children's Advantage, you're working on implementing adventure therapy, which is super cool, and I don't know nearly enough about it, but everything that I do know is cool, so I'd like to hear any thoughts that maybe, Mary, if you'd like to share a little bit about that. I feel like we could all benefit from hearing a thing or two. We're really just going to leave it up for discussion now. What other treatment options have all of you guys used?
Can you hear me?
Yes.
Okay. Well, at Children's, it seems to echo in my part.
Can you mute your computer and then just talk through the phone?
Yeah.
Because I think that might actually stop the echo. You might have to unmute.